Please join me in welcome Mr. Steven Burd, and I'll have more formal introduction, okay? Mr. Burd served as the Safeway CEO for unprecedented 20 years. During his tenure, the company outperformed the SP 500 index on total shareholder return by 34%. That's impressive. That's impressive. I'm a marketing guy. You know, I don't get the number right, but that looks really good. This achievement is particularly noteworthy given the narrow margins of the supermarket sectors, you all know that, and the dramatic changes in the food retailing environment. That make that 34% remarkable. Well, at Safeway, Mr. Burd was active participant in the policy discussion at the national level that led to the Affordable Care Act today. In addition to testifying before several committees, he addressed both the Republican and Democratic caucus of the U.S. Senate. Well, Mr. Burd argued for a market-based solution to the nation's healthcare challenges. This discussion did lead to amendment to Affordable Care Act, making the only amendment that passed among dozens that were proposed. The so-called Safeway Amendment, what honor that is. The so-called Safeway Amendment permit self-insured employers to differentiate employee health care premiums as much as 30% of total cost and potentially 50%. That's a huge, huge advantage. And Safeway is recognized throughout the entire business community for holding its employee and employer per capita health care costs nearly flat for 8 years. Well, the national health care costs were skyrocketing at once over 70% at the same time. That was accomplished by introducing a market-based solution that strengthened personal accountability, employee personal accountability, create employee incentives to encourage healthy behavior and provide transparency for healthcare services. Mr. Burd believes that a market-based solution to healthcare could lower the nation's healthcare cost $800 billion per year. And Mr. Burd now is engaged full-time in the healthcare sector. He recently formed a company, Burd Health. You see the logo, Burd Health in the right corner, right lower corner, to help large self-insured employers manage their healthcare costs. Please welcome our distinguished speaker, Mr. Steven Burd.
Oh, thanks. All right, thanks. Well, I'm going to start with a couple of disclaimers, I think. Number one, I'm not the guy that's selling Safeway, okay? Number two, I'm not the author of the Affordable Care Act. As I think about the Safeway Amendment, had we been better acquainted, had there been maybe an honorary doctorate thrown in, that could have been the St. Mary's Amendment, okay? Okay, this was a difficult thing to prepare for because I'm not really sure what everybody's knowledge is about healthcare, so I'm going to spend a few minutes on the front end trying to bring everybody up to a level of knowledge that I think will help you understand the last two sections of my discussion. So just by way of a discussion guide here, I'm going to talk about the U.S. healthcare challenge. In fact, you will hear politicians talk about it, even the president, during the legislative effort. Clearly, they would call it the healthcare crisis. And probably no sector of the U.S. economy has been talked about more over the last 20 years than the healthcare sector. And before I finish here tonight, I think everybody will understand why that's the case. The healthcare challenge seemed to have not affected Safeway. As Ann mentioned, Safeway's costs, the numbers that you quoted are what we did with the non-union workforce. When you look at all 185,000 employees, or actually down 15% over an 8-year period. And I'll talk a little bit about how that happened. Then I want to talk about what really were the factors that made Safeway successful, because they can be the identical factors that would make any company in the United States successful in controlling their own healthcare costs. And then finally, I'll talk a little bit about the future of healthcare, and I'm willing to take any and all questions. The Affordable Care Act, as some of you know, is 27,000 pages. I'm prepared to try to respond to any questions you might have about that. And the regulations themselves are 27,000 pages. So that's really what you get when you attempt to regulate a large sector of the US economy. You can't do it in 30 pages. I could have written a healthcare bill that would have been about 30 pages long. And in fact, at one point I said to several senators, I said, if I could get 30 large companies to equal the experience of Safeway, would you in fact, I was talking to Democrats and Republicans, would you let me write the next bill? And universally they said yes. So ironically, that's why I created Burd Health, because we should have about 30 companies sometime in the next 18 months that will replicate that experience. Okay, by way of background, when they talk about the healthcare crisis, they talk about a crisis of coverage, namely that about 15% of Americans are not covered by healthcare insurance today. And then the other fact is that costs seem to be escalating at a rate much higher than consumer price index in general. In fact, this is a different way of looking at these numbers than you're accustomed. This is the CPI from 1980. This is the annual increase from 1980 to 2012, excluding healthcare. So that part of the economy inflated at 3.1%, and healthcare inflated at 8.1%. Another sort of factoid that you might want to keep in mind, particularly anybody who's in school here and wants to think about a career, you might want to think about healthcare, because the healthcare sector is the fastest growing piece of the US economy for the last 50 years. And it's not going to slow down, particularly with the aging population. So as a percentage of GDP, we've gone from 9.1% in 1980 today, say 2012, 17, 2. And I don't believe the Affordable Care Act is going to slow this rate down. Although Ken Shackman, one of my associates, we intend to slow it down, certainly for our clients. But that should reach 25%. And there's no sector in the US economy that even compares to that. And that's why I think it's so commonly talked about, in print and in the media, because it's a big growing problem. And I'll probably say this again later, but it could bankrupt a nation. The reason I gave you that $800 billion number, I know it's hard to say 800 billion, but that $800 billion number, there's no question that we could lower the nation's $2.5 trillion bill by 800 billion. And if you just think about it, that would pay off half the national debt in the next 10 years, which is a pretty remarkable number. So this is something worthy of all of our concentration. And if you're not focused on it and are just kind of a bystander, which is also possible, you can see how this is going to affect your life. I gave a talk in Hawaii. I thought about borrowing from that. What was the title? It was Live Longer, Feel Better, and Have More Money. I was actually trying to solve the healthcare crisis simultaneously with the debt crisis. And I'll take questions on that later. I'm sure several people here would like to have more money. Okay, so let's talk about the Affordable Care Act was supposed to deal with coverage, and it was supposed to deal with cost. And now the Congressional Budget Office, their new projections are that costs are really going to go up. I think that's what most of us thought. But they did make progress on the coverage issue. The amount of progress that the Affordable Care Act has made as of so far is still a little bit unknown, because they didn't bother to ask people that signed up for either the federal or state exchanges whether or not they were previously covered. So we don't really know whether the 8 million that signed up for those exchanges are actually new to insurance. But I'm confident there are at least 3 million people that are new to coverage, and that'll probably grow as we move through the year. but they really focused on access. The increased costs are basically financed by increases in taxes. Everybody here, well, Bob, you might be an exception. You don't work anymore, right? Okay. Paul, you guys, you just listen to this. Everybody else in this room had an increase in their taxes because the Medicare tax now, it applies to dividends and it applies to interest income as well. It didn't used to apply to those. And then they added about 0.8 to the Medicare tax. In fact, for me personally, my Medicare taxes throughout my business career have exceeded my, contributions to Social Security by a factor of 20. So, hopefully they'll let me take advantage of Medicare, since I'm a big payer. So the result is that we have higher health care costs that are borne by the private sector through increased cost shifting. The reason everybody in this room should like to have everybody in America have insurance is that if you don't have insurance and you need care, you may not get the best of care, but no hospital in the country can turn you down. So you will get care. I'm going to show you the economics of a Bay Area hospital later in this presentation. So you'll see the negative drag of the uninsured and the underinsured. And then, of course, all of those that are in private sector companies with normal health care plans were basically paying that bill. So I was a big fan, not popular among my Republican friends, advocating for the individual mandate. I would have done it differently than the Affordable Care Act has done. But I think it's very important for everybody to be in the game because the rest of the working folks end up paying for them. So let's talk about the challenge. Per capita healthcare costs in the U.S. Have been twice that of other industrialized nations. And I'm going to show you a chart. And I'm going to begin to sort of peel the onion back and give you a sense for why the costs in this country are really the highest in the world. These costs have been growing at more than twice the rate of the CPI for at least 2 decades. And the healthcare delivery system that we have, and the best way to describe that, think of the delivery system as those are the healthcare providers, whether it's a clinic in a Walgreens, or whether it's a private practice, or whether it's a local hospital, or a single practice, or multiple physician practice. Those are the providers. And how we get services from them is very inefficient. The healthcare sector, the largest sector of the U.S. economy, does not have the benefit of having cost and quality information readily available. So you can't behave and interface with the delivery system as you would any other sector of the U.S. economy. Pretty amazing that if any of us wanted to find out what it would cost to buy a new iPhone from Apple, we could go on our existing iPhone, or we could go on an iPad and we could instantly determine what that would cost and who sells it within 10 miles of us. You can't call any hospital or clinic and ask them what it's going to cost for a colonoscopy. They can't tell you. And they can't tell you the likelihood of having your colon perforated in the process. I hate to get into that this early in the evening, but that's what I mean by an inefficient delivery system. And so left unchecked, our costs will continue to rise and, in fact, stand a good chance of bankrupting the country. So this is a conversation I had with the Bay Area Hospital CEO. This data is probably about 4 or 5 years ago now. And we were talking about the economics of each of 3 groups of people. And so 1/3 of their business represents people who are uninsured. Another third represents people who are underinsured. Think of those as Medicare and Medicaid. Anybody that's taken any economics courses here knows the term variable cost and fully allocated cost. Medicare will never pay more than variable cost, and is not taking any of the burden of the fixed cost of the local hospital. So we think of those as underinsured. So they lose $90 million on the uninsured. Because what do? They have a price structure. We call it rack pricing. If you go to the hospital as an emergency, you have an appendectomy, you're uninsured, they'll give you a bill for probably $30,000. And the reason that bill is $30,000, for me, if I had an appendectomy, my bill would probably be maybe $15,000 or $18,000 For the uninsured, it's 30. Why is that? Because they expect to get no more than about 25% from the uninsured over a period of time. And so the price structure that is hard to find, if you can find it, is a pretty meaningless price structure. It's designed to live in this crazy world of uninsured, underinsured, and fully insured. So they lose $90 million on that group, $20 million on the underinsured, and then they make $130 million on everybody that's fully insured, which I'm gonna guess, just looking at the age of this group, that's largely everybody. Most of the people in this room would be fully insured. Some are on Medicare, but most of us would be fully insured. So the reason you want everybody in is we wouldn't be burdened on the 130 side with a $90 million loss to start with. And that's why having some kind of requirement that people have health insurance is a good idea. And I'll express it in another way. If we had a libertarian up here, I'm not sure he and I would agree, but the way I always understood our system of government here is that we have all these freedoms until my freedom begins to interfere with somebody else's. Like if I come on their property and start painting the front door of their house, I'm infringing upon their freedom. So when you are uninsured, you're infringing upon the freedom of all these folks who have to pay for you. That may not be the best way to state that, but we're in a small group, and I'm just going to be as candid as I know how. Okay, I talked about U.S. healthcare costs being double that of other industrialized nations. So I've just picked some countries here, somewhat at random, but we're almost 3 times Italy, almost 3 times Japan, essentially twice France, and almost twice Canada and Switzerland. Now it's not because we don't have a single nationalized single-payer system. It's because of a lot of other factors, some of which I'm going to describe in a minute. But, well, I'll go back to that for a second. What is interesting about this is that Ken Shackman and I believe that it's quite possible for America's cost to come down to around 134 to 140. This is an index. But there's no reason for us to be that much higher than the rest of the world. Some of the factors that contribute to it is that obesity, which is a major factor in healthcare costs, those that are obese. We have the highest adult obesity rate in the world. I'm going to contrast that with some other countries in a minute. Sometimes if you have, remember, we don't have a good market, and so we overpopulate the U.S. geography with diagnostic equipment, which you're going to see leads to more lab tests, more MRIs, more CT scans, and that adds to our costs. We often overtreat patients. Doctors worried about their liability. Why not call for another scan? Why not start with a CT scan, move to an MRI, and then finish with a PET scan? And if they all tell me the same thing, then I have a high degree of confidence that I'm right. But much of that is unnecessary. The other, which I tried to fix this in the Affordable Care Act, I had what I thought was a really good solution. The U.S. and other market-based economies pay for all of the pharmaceutical research in the world. And I know we've got somebody here from Genentech and after that Roche. And it'd be interesting what you think of this. The reason we pay for it is because those companies are buying as country monopolies. And the UK says this is what we'll pay. And Canada says this is what we'll pay. And France says this is what we'll pay. And so I had suggested to both Republican and Democratic senators that we add 2 lines to the Affordable Care Act. And these lines we would lift from defense contractor contracts. Every defense contract in the United States today says that that defense contractor cannot sell those missiles, airplanes, or weapons to any other country at a lower price than he could sell in the United States. If that's what the Affordable Care Act said about pharmaceuticals, well, guess what? France would complain and Canada would complain, and frankly, I think some of the pharmaceutical companies might complain, but at the end of the day, All of those guys are going to get their pharmaceuticals, and you would solve that fourth bullet with one stroke of the pen. Our delivery system does not operate in a market-based economy, and what I'm meaning by that is we don't have cost and quality information, flat screen TVs, cellular phones, just about anything you can imagine, used cars, new cars. So look at the obesity numbers. Japan is at 3%. If this isn't a comment on the Western diet, nothing else I could put up here would say it any better. And so Japan is at 3, and let me tell you, they're bummed about it because that rate has doubled in the last 10 years. And they're taking all kinds of actions in Japan that don't fit with the kind of freedoms that we have here necessarily. But you can go all the way up to, let's say, Canada. 2/3 of these countries have an obesity rate lower than ours. I can't help myself here, Ken, but to tell you, this is a quite solvable problem. And I want to just share with you an anecdote. I don't have a slide for this, but every time I worked on a problem at Safeway, the problems we work on today, the first question I ask myself is, does it scale? Does my solution scale? Because if it doesn't scale, it's not going to help the nation. And what I'm going to tell you later about the solution for healthcare, it does scale. But here's an interesting comment about obesity. In the mid-90s, and this is documented in a book called Spark, a school district 203 in Naperville, Illinois, a PE teacher in the 7th and 8th grade classes decided he was going to shake things up. And he decided that the smart thing to do was to have every student, when they came to gym class that day, run a mile. And so since 1995, every junior high, every high school in that school district 203, you run a mile when you first get there. And you get a grade based on how well you run that mile. And it's basically a function of what your heart rate is relative to theoretical max when you finish. So someone who runs it in 12 minutes can score as well on that grading system as someone who runs it in 4.5 minutes. And so what happened to the school district? The book Spark is basically trying to, it's drawing a correlation between physical activity and the ability to learn. It has an effect on sensory perception in the brain. And so they not only were working on conditioning, and then team sports were secondary. So the student body, particularly in high school, if they had a calculus final, they would go swim a mile in the morning before calculus. They'd go to the gym and they'd run laps. I'm not going to talk about obesity, but the average US teenager today in high school, 30% of that high school population is overweight. In this school district in Illinois, the answer is 3%. Now, what did it do to test scores? They were so proud of what they were doing, they decided to enter an international competition on, we hear about how American test scores are in a constant decline. And so they didn't send their merit scholars. They sent the entire student body. And they took first in science and 6th in the world. Little Naperville, Illinois. So it just proves that there's a technique that works out there. Here's another factoid for you. How many states in the United States require PE in high school? I'll help you out. 1. 49 states don't require it, only 1 state. It happens to be Illinois. It's probably one of the best parts about Illinois, given the fact that all their governors seem to end up in prison. But the fact of it is, I'm fascinated by the fact that they simultaneously solve, some of the educational issues while solving obesity and conditions of overweight. So it can be done, and we'll show you what we did at Safeway. MRI units, it's just a feature. I just wanted to give you some anecdotes here. So we have roughly 4 times as many MRI devices in the United States as they do in any of these other countries. So guess what? We do more MRIs. than all of these other nations by quite some margin. In fact, there was a study, I guess it was at the Dartmouth study. What they found was healthcare costs were correlated with the more physicians you had in a community, because there was no transparency on cost and quality, the higher were healthcare costs. And if you don't know this, there is no correlation between cost and quality in the healthcare space generally. And that's a sad fact. Now, quality information will become available, as will transparency on cost, and I'll talk more about that later. Let's look at angioplasty. Dean Ornish, who runs a prevention center for cardiology over in Marin County, has been on this for a long time, advocating lifestyle changes instead of angioplasty. He's actually got demonstrated cases where someone was waiting for a heart transplant. He gave them a rather extreme, Dean Ornish diet, and they walked out of the hospital without a heart transplant. So what you find, and I'll show you later, all the chronic conditions that produce all this high cost, you'll find that the vast majority of these conditions are behavior-driven. So, a lot of challenges, costs getting out of control, no transparency on cost and quality. But I think this is the single best time to be in the healthcare space. So when I left Safeway in May of 2013, I knew I was going into the healthcare space. I actually didn't know what I was going to do. I set up an office about 1.5 miles from my house, and I thought I was going to devote most of my attention to public policy. But I made a turn in July of that year. I was challenged by a friend of mine to start a private sector company. And I'll just tell you, he's the only other investor in my business. His name is Mike Milken. I mentioned to a couple people earlier today, if you want to read something that's absolutely fascinating, there was a Fortune article written about Mike Milken, and the title of the article is "The Man Who Changed Medicine." Mike Milken has the single largest footprint in medical research in the world. In the world. I could tell you, the article doesn't say this, but I've known him for 15 years. I could tell you there are 1 million people walking the planet today because of Mike Milken. And he and Sumner Redstone just established the Milken Institute of Public Health at George Washington University about 2 or 3 weeks ago. And so, great partner, great Rolodex, deeply knowledgeable about medicine and medical research. And we intend to make some big changes out there. The ability to prevent and treat disease has never been better. With the mapping of the genome, I mean, it has changed the world. I met with a guy at Johns Hopkins last week. Ken and I were there. And when I was at Safeway, we raised a lot of money for cancer research. For those of you that don't know, I had prostate cancer, 14 years ago. For Mike Milken, it was 21 years ago. And we had started raising money for breast cancer and started raising money for prostate cancer. And if you live in this area, you've probably all made a contribution. Those contributions added up to some $200 million. Sometimes projects don't get easily financed. And so Safeway personally financed some work that was designed to end metastatic prostate cancer. And it was basically built on the theory that if we heat a cancer cell 6 degrees above normal temperature, we can subject that cancer cell to permanent death. And that was based on some earlier research where we have essentially cured a form of cancer. 95% of patients with that form of cancer are now curable today. So we met with a guy. I said, so where are we on this thing? And he said, okay, it worked in mice and it worked in rabbits. And he said, now what we need to do is we need to build, what you have to do is you have to build an electromagnet that is large enough to take the entire human body. And this technology requires, you use nanotechnology delivery system. So you take iron particles, 1,000 of them equal the width of a human hair. And you inject that with a fluid into the body. they're attached to an antigen that seeks out the cancer cells. It attaches to the cancer cell. The electromagnet heats the cancer cell 6 degrees, and then you zap it either with radiation or chemo. Because the struggle with cancer is permanent death. Otherwise, you're sort of chasing this around. And he needs $15 million to build this electromagnet, and I think I can get him the $15 million. And I want to talk to some other guys. One of the reasons I almost went into public policy was that I want to change the way medical research is financed in the country. I'll leave that for a Q&A if you want to talk about that later. But there's so much going on in immunotherapy and genomics that this is the best time, whether you're in research or whether you're on my side of the equation, it is the best time to be in the space. The pace of scientific advances is increasing at an exponential rate, and the cure for controlling costs, improving outcomes, sustaining good health has already been discovered. And that's part of what Burd Health does. So how do you unleash this cure? Our view is that you create market forces where they don't currently exist, and I'll explain exactly how we did that in Safeway. So we didn't need any legislation on the part of the government. We didn't need anybody's help. We could create a market system inside a Safeway, and it worked. One of the things that we needed to do is we needed to give patients, or consumers, if you will, enough skin in the game so that they had an interest in shopping for price. If we could make price and quality information available, they would respond. Now, if they're overinsured and have no financial burden at all, they're not going to respond. To become successful shoppers, we need price and quality information. Again, just a little anecdote, and I would tell you that I probably already spilled the beans, but I've voted largely Republican over the years. But when I worked on healthcare, I had to make all kinds of friends on the Democratic side of the aisle because they basically controlled the Senate, and that's where things were happening. I actually became an advisor to Hillary Clinton when she was running for the nomination, and it was a fun relationship because she knew I was a Republican. She accepted me because she thought I knew something about the space. And I remember being on a phone call. I won't tell you who all the players were, but they were all CEOs. One of a very renowned multi-billion-dollar market cap technology company. And Hillary Clinton asked the following question. She said, how long would it take to develop this transparency tool that would give consumers knowledge about price and quality? And the CEO of the big tech company answered first, and he said, about 10 years. And so I said, well, I'm a grocer, but I'm going to tell you 12 months. And 12 months later, we had a transparency tool at Safeway. And we'll show you some information on that. And the reason I said I could do it in 12 months is because I'm a big believer in what you probably use this in your teachings, the 80-20 rule, where you try to get 80% of the benefit with 20% of the effort. So you only focus on the costs that really matter. So you get the big stuff done first, and you worry about smaller stuff later. And the other thing you have to do, and this is the least understood of the cure, is you need health plan designs that motivate shopping and engagement. So there's a company that just went public. We were actually their pilot project. It's called Castlight. They went public recently. Let's see, they had $13 million in revenue last year. They lost $62 million. And they went public at a price of $3.6 billion. Because they have the best transparency tool in the space. But that transparency tool given to a company that doesn't have a plan design that makes use of cost and quality information is useless. And so you have to do something about the third bullet. So why am I so fixated? I told somebody earlier that if Milton Friedman could could be resurrected and come sit in the front row here, I would sit to his right, okay? I just believe in free market principles because I've seen it work so many times. And so think about cell phones. The first cell phone I had was the size of a brick and weighed about 3.5 pounds. And it didn't do much but dial a 10-digit number. That was it. And then after the brick disappeared, some of you may have owned a StarTAC. Well, I wanted to be an early adopter. I bought the first StarTAC phone. It cost me $3,400. It doesn't have nearly the functionality of something you can get for $19 today. And so my point is, when cost and quality information becomes available and market forces are allowed to work, I can't think of an example where quality doesn't improve and cost doesn't come down. That should be the story in healthcare. Let's look at computer prices. You know, I happen to, boast I was alive before the cell phone, and I was alive before the personal computer, and so were you guys, right? And so we've seen this happen, and we've seen it happen with other products. So let's talk about Safeway as a case study. In 2005, Safeway's healthcare expense was $1 billion a year, now covering 185,000 employees. Costs were escalating at the rate of 10%, and so that meant $100 million a year. That looked like something worthy of the CEO's time. And for those of you that have had a chance to get to know me, I was a very hands-on, still am, very hands-on CEO. I've got to touch the knobs myself. I didn't just hand out assignments. So I was deeply engaged in this process, as was Ken Shackman, who hails from Moraga, we should say, right? Moraga's own. All right. Once the root causes of rising costs were understood, we launched a market-based solution. And so in 2013, remember I left in May, but the trajectory was that Safeway's costs were going to end the year at about $850 million. And I'll demonstrate to you that we have a much healthier workforce. In fact, I wrote an article, an op-ed piece in the Wall Street Journal. It could have been 5 or 6 years ago now. And I compared what we were doing to the automobile insurance industry. And, so it wasn't a stroke of genius. It was just being observant and sort of connecting the dots. People talk about vision and they think it's like forecasting the future. I think peripheral vision is just as important. And I think real visionaries, guys like Steve Jobs, they connect all the dots. They have better peripheral vision. When Joe Montana, in his later years, it was his peripheral vision that allowed him to see 5 receivers and still be competitive. And so the older you get, maybe the more experience, the better your peripheral vision. So $850 million. So what happened here? Again, I've indexed the cost so that most of the other participants in the US healthcare space, meaning large companies, had a 72% increase in costs over that 8-year period. Safeway had a 15% decline, going from an index of 100 to 85, 1 billion to 850 million. So, what were the key factors responsible for their success? Again, making good use of things like the 80-20 rule, or in this case, the 70-30 rule. 70%, this is a widely accepted number by the entire medical establishment, from Cleveland Clinic to Johns Hopkins to UCLA to UCSF, 70% of healthcare costs are driven by behaviors. And Ken and I looked at that and they said, this is really cool because we think we can influence behavior. In fact, we would argue that we don't think behavioral change is as hard as most people think it is, as long as you focus on things on the margin. And I'll show you some of the things that we did. So this is really good news because it says that we can influence behavior probably by elements of plan design and provide information that previously didn't exist, and people will respond. Second is that 4 chronic conditions, and I'll show you what they are in a moment, explain 74% of all costs. Now I'm going to contrast this with the produce department over here in the Lafayette Safeway. They carry 600 items. And when I was deeply engaged in improving the profitability of Safeway, we looked at things like produce. How much shrink do we get? How much do we have to buy that we have to throw out? We call that shrink. And if somebody came to me and they said, great news, 74% of all produce shrink is confined to 521 items. That information is worthless to me. If instead they said 74% of all of our shrink is confined to 4 items, whoa, suddenly a very solvable problem. And that's what we learned early on in this process. And we also felt that if we could create a market, change our benefit plan, improve the health of the workforce, and lower the employee and company costs. So when the op-ed piece went out, just again, an interesting factoid, I guess, that op-ed piece broke. You could find it in the Wall Street Journal. Just say Steve Burd, Wall Street Journal, or Steve Burd healthcare costs. It'll pop up. The day that came out was the day that I addressed the Democratic caucus of the Senate. Okay, Ken likes to say that I addressed 101 senators because who was the guy from Pennsylvania? Arlen Specter was a Republican when I first addressed the Republican caucus, and then he became a Democrat when I addressed the Democratic caucus. So the only person ever to address 101 senators. But my op-ed piece came out, and Rush Limbaugh devoted 17.5 minutes of his radio show, which I'm sure you could also get online, and he was expecting he was expecting that I was just going to get slammed and people were going to go after my tax returns and all this kind of stuff. But he was applauding, this article. And then our own senator here, from California, she was applauding what I'd done. So I really fulfilled, both ends of the spectrum, at the same time. And I got an email from the CEO of UCSF, and he said, you make it sound so simple. He said, if people take better care of themselves, they'll have less need for health care, and health care costs will go down. Yeah, that's it. It really is just that simple. And it's exactly what we did at Safeway. So for your benefit, 33% of all health care costs are associated with cardiovascular disease. And 80% of heart disease and stroke are completely avoidable. I'll use my own example. Maybe this is dangerous, but so I have a bad family history. A mother heart attack at age 45, father at 50, brother at 52, uncle at 37. So the numbers don't work in my favor. So I've had a cardiologist since I was 40. Maybe I should have gotten him at 37. I keep my cholesterol very low, and I do 8 cardio workouts a week. So that's how you beat the odds. That's why you kind of want to know what your genetics are, so that you can behave differently. So the beauty of this is it's the biggest chunk of our healthcare costs, and 80% of it is avoidable because it's driven by behaviors. In terms of cancer, 60% of cancers are avoidable. And the other 40%, if caught early, are actually quite manageable. In fact, unless you really follow the space, you have no reason to know this, but I read everything I can in healthcare, particularly in the cancer arena. There are blood tests being developed today that will eliminate the colonoscopy that you should get when you turn 50. And they'll be able to detect even polyps in a blood test. Pancreatic cancer, the first ones will be colon cancer, lung cancer, and pancreatic cancer. And pancreatic cancer, which is very difficult cancer, it takes 17 years to metastasize. Steve Jobs would be alive today if he had followed the advice of his doctors. They diagnosed his pancreatic cancer quite by accident before it had metastasized. And he ignored their advice because he wanted to try some alternative treatments. When he came back and said, all right, I'm ready, they said, I'm sorry, it's metastasized. And he didn't do well after that. My point is, with the way science is moving, If you can detect, pancreatic cancer in its 5th year, you know where it is. It's in the pancreas, and you can now deal with it. You always want to deal with cancer when it's small. And so in the next 18 months, there will be 12 blood tests that will detect various forms of cancer. Diabetes. There's type 1, which is generally considered juvenile diabetes, and then type 2, which used to be called adult onset. You usually get that as an adult. With type 2, about 80% of that is completely avoidable, and not known to even a lot of type 2s is if you are diagnosed with type 2 diabetes, you can often reverse that. And what it takes is a change in how you eat, maybe a loss in weight, and more exercise. But you can actually reverse type 2 diabetes, but only up to a point. If you've had it for 10 years, and I'll know in a couple of months what that exact fine point is. There's a test you can take. It's called C-peptide, and it'll actually tell you whether or not your pancreas is beginning to shut down and how much time you have left to actually reverse your diabetes. And then conditions of overweight. Nearly all can improve in this category. So there you've got 74% of the cost, much of it behavior-driven, and that's a very good piece of information to know. So what are some of the big causes for why is this taking so long to get all this stuff fixed? Well, if you go back to 2005, the vast majority of American workers were overinsured. Had the unionized workforce at Safeway, for example, back in 2005, had no premium. That would be common to most union organizations. So there wasn't much skin in the game. They might have had a couple of co-pays and a little co-insurance. But if healthcare costs are, if you're overinsured, it looks like a free good, and free goods get overconsumed. And so you don't want free goods. Health benefit plans generally lacked incentives in 2005 to reward good behavior. That's still true for the vast majority of healthcare plans today. Cost and quality information largely absent, not at Safeway and a handful of other companies. Providers of healthcare, little incentive to be cost conscious because they're worried about a lawsuit. And they're paid on what they do, not the results they provide. And that's beginning to change. And then too many consumers are not a part of the system. That's that uninsured group I talked about earlier. So let's talk about what we did at Safeway in terms of plan design. We increased the personal accountability so employees' interests were better aligned with the company's interest, so that they had an equal stake in whether or not wise choices were made. We encouraged employees to embrace healthy behaviors by offering financial rewards. And we did it differently. We have yet to find a company that's done anything quite like this. If someone had a BMI of, let's say, 35, we rewarded them if they reduced that by 10%. So if they got down to 32, or let's say 31.5, they got a reward as if they did not have an elevated BMI. And we did a number of other standards, healthcare standards, which I'll show you in a minute. And so we rewarded them for progress, and we rewarded them for success. And that's all permitted. It was permitted under the law before the Affordable Care Act. And thanks to the Safeway Amendment, you can differentiate to a much greater degree, because some of the behaviors that people are engaged in, like smoking, can be really expensive, and we'd like to discourage that. And then we provided cost and quality information through the Castlight tool about healthcare services before you actually had the service, and I'll show you a couple of examples here. So why are behaviors important? Because they can be expensive. Now, when I threw this number up at the Cleveland Clinic, $1,796, that's the average cost. That's the hard cost, not the soft cost, not loss of productivity, not going out for a smoke break. That's the soft cost. And Toby Cosgrove, the CEO of the Cleveland Clinic, puts that number at close to $3,000. Well, if before the Safeway Amendment I could only differentiate premiums as much as 20% or $1,000, I couldn't do much about smoking. Obesity, you pay more for somebody that is obese, lack of exercise, you pay more uncontrolled hypertension, uncontrolled cholesterol. Let's take on the right side of the chart where people have now been told by their doctor they have these conditions. You have coronary artery disease, you need to do the following. 32% of them are non-compliant. Hypertension, non-compliant. High cholesterol, non-compliant. Diabetes, non-compliant. Overweight, non-compliant. You can actually design a healthcare plan that incorporates all of these elements and improve the compliance of people that are part of your plan. So these are examples. They're probably a little bit different today, but we had a standard for cholesterol, not set by Safeway, but by the top 10 medical centers, what they think is a good standard. Blood pressure standard, BMI standard, smoking. We wanted no smokers. And then hemoglobin A1C, which measures the average glucose level in a diabetic patient over about a 90-day period. So it's a better measure than what you might get on a spot glucose reading. And so the way we looked at this was we said your behavior, healthy behavior, becomes a form of currency. And the healthier your behavior, the more currency you have, i.e. these dollars, and you can buy down your premium at Safeway. And we offered two plans, one that had biometric standards, one without. 85% of them took the one with biometric standards. Then we created a culture of health and fitness, and the reason I threw fitness into the equation, that as you age, your mobility is everything. And being fit is going to make you more mobile, and being more mobile is going to make you healthier. My mother-in-law fell in the bathroom at age 85. She didn't have the arm strength to get up off the floor. Her 80-year-old sister didn't have the strength to help her get off the floor. And that's the day I started strength training. Because, when I fall, I want to be able to get up. And it does wonderful things for coordination as well. So what are the hard facts? How much success did we have in improving the health of the workforce? 2 years after installing these standards, of all those that failed the blood pressure standards, 73% of them now pass. That number is probably higher today. Glucose. For those that failed the glucose standard, and this one is one of my favorite ones because there's no magic bullet here. There's no pill you can take. The only way you can lower that glucose level is to eat differently, lose weight, and exercise more. 45% of those that were pre-diabetic ceased to become pre-diabetic. Would be fun, I think, Ken, if we had access to the data to see how many diabetics are no longer diabetics. I remember we had a retail operations officer in Portland who was diagnosed as a diabetic, type 2, and a year later he was no longer diabetic. And it was because of how we encouraged him and others to behave. Cholesterol level, those that failed, 43% passed it. Tobacco, 35% of our smokers quit. And a lot of companies that have a tobacco standard, it's not the Reagan standard of trust but verify. It's just a standard called trust. They asked their workforce. We did that when we started. We asked them if they smoked. Guess what? Only 11% of the Safeway workforce smoked. The next year, we decided to verify. 20% of the workforce smoked. Okay? So again, remember, they volunteered to get into this plan because they wanted access to the lowest possible healthcare premiums. And then BMI. We're probably the only company in the country that actually had a profile, a BMI profile of the entire workforce. So just looking at BMI, 21% of those that were above 30, 2 years later were no longer above 30. And 4 years later, 71% of them were still below 30. I've had a number of world-class physicians tell me that if this were not a process, if I had in fact created a drug, and I actually thought about creating a placebo and say, take this and do these things, okay, that we would outsell Lipitor in its heyday, which is the #1 drug of all time. because no one has been able to match those statistics. So let me give you an example of how we encourage people. You know, it depends on what the body weight is, but let's say someone that was interested in losing, you know, 10 or 15 pounds, maybe even as much as 20. You know, we would encourage them to think about getting half a pound through reducing calorie intake, and then another half a pound through burning more calories than you normally would in the course of a week. So if you get a half a pound for each direction, it seems like a good balance. It's 1 pound for the week. We created the concept of small groups, actually modeling off of the Bible studies that we had at Hillside. Hey, if it works for Bible study, how about for fitness? So we created small groups, over 1,000 small groups on any single day operating in Safeway today, collection of coworkers, maybe some family members. We created a website. They each set their own targets. They don't have to tell anybody what they weigh. And every Monday morning, they confess to what their new weight is. So I was in the very first small group. And as the CEO of Safeway, I couldn't allow anybody that reported to me to see me miss my goal. And trust me, they felt much the same way. We put calories and other nutrition content in all the items in the cafeteria, stopped subsidizing, you know, cheeseburgers and fries. We carried them because I believe in free choice. Milton Friedman would be proud. But we didn't subsidize, you know, things that were considered to be less healthy. We only subsidized salads, low-cal vinaigrette dressing, and those things. So if you're going to lose a half a pound through exercise, and I could talk for 3 hours just on strength training, you have to incorporate strength training. If you don't, for every pound you will lose a pound of muscle. And if you're over 50, gaining muscle can be difficult. And you don't want to lose any muscle. So you have to do strength training, and then add aerobics because you want to have a good aerobic system as well. And those are the things that you would do to burn more calories. And then lastly, we offered, you know, websites that gave people hundreds of ways to do this and incorporate. My goal was to, what do I do for the soccer mom and the soccer dad? Shoot out of the office at 5 o'clock, over to the field, probably have dinner, you know, at McDonald's or Burger King. How are they going to engage in this? It was easy for me as an empty nester, and I could hit the gym, you know, 5 days a week, no difficulty. And so we created some things for them. So let's first of all start with calories. This is actually the easy one. We believe that behavioral change, in order for it to stick, it really needs to be happening on the margin. And I made a list of this just the other day. You know, for lack of a better term, I looked at all the unhealthy stuff that I eat and how many calories they were. And so we tried to say to people, you know, do you really need, you know, the latte, you know, every single day? You know, could you, for the next 12 weeks, just have coffee? Maybe you could. If you didn't like that, do you really need blue cheese or ranch dressing on your salad if you eat several salads a week? Or could you do with a low-cal vinaigrette? Everyone on this wheel is a half a pound a week. I remember doing this talk before a group of store managers in Washington, D.C., about 200 of them. And 2 of them came up to me at the break. I was giving my healthcare speech. And they both announced to me that they had each lost 100 pounds in the last year. I said, how did you do it? They said, we used to drink 4 regular sodas. They were all store managers every day, and we switched to diet. And they lost 100 pounds. A chocolate chip cookie, you know, on the way to dinner. A handful of raisins instead of M&Ms. Mars wouldn't like that, but they're not here. Okay, so let's look at the calorie burn side. We invited, you know, people to, you know, put on a headset, you know, and just as I'm doing, pace the floor. If you talk on the phone 6 hours a week and you pace the floor while talking on the phone, you will burn a half a pound. And so that just is integrated into your activity. You don't need to join a gym. 40 minutes of weight training 4 days a week would do that. If you want to play golf on Saturday, forget the cart, carry your bag, and walk. And unless you're hitting a dead center down the fairway, you're probably going to walk about 4.5 miles. All right? 30 minutes of walking at lunch, and then walk after dinner. Go walk the dog. The dog needs exercise. 45 minutes of walking at 4 miles an hour, 6 days a week. There are a number of things you can do. You can walk up 5 flights of stairs instead of taking the elevator. Just incorporate it into your daily routine. So back to transparency. Unless you know about this, I mean, I referred to this with the US Senate as the smoking gun of healthcare. Because until we got deeply into this, now it's been talked about, you've read articles about it, but I'll tell you, before any articles were ever written, we stumbled across this stuff, and it was amazing. So an MRI of the spine, I could pay $900, or I could pay $3,600. And when I walked in, I didn't have a clue whether I was at a $900 facility or $36. Colonoscopy, you know, I didn't know if I was going to get an 887 or a 7245. And guess what? If you called, they couldn't tell you because they didn't know all the revenue codes and everything. What hospitals do, best advice for you, if you have a 20% copay, is get this stuff done at standalone imaging centers, ambulatory clinics. Now, you can't do everything in an ambulatory clinic, but try to stay away from CT scans and MRIs at hospitals because the finance team is trying to burden their fixed cost with these different procedures. I want you to imagine this. You're a Safeway shopper, and you have a loyalty card. And if you walked into a Safeway store and just scanned your loyalty card, and at the end of the month you got a bill, and it said you spent $1,000 with this last month, thank you, and your employer picked up $800 of that, you owe us $200. And then come October, they said, congratulations, you've exceeded your out-of-pocket maximum. Now everything in the store is free, okay? The high-end wines are located at about eye level, you know, on aisle 13. What do you think Safeway would charge for a gallon of milk? I would say about $17, $18. If there were no shelf pricing, that's healthcare today. So if you wanted to be a consumer, you have a very hard time becoming one. So it doesn't matter what procedure you pick, there's often a tenfold difference. Now, this is kind of an interesting slide because everybody wants to go to the best doctor, right? Well, the professional fees are in red. They're not driving this bus. It's really room and supplies, or if you will, the fixed cost of the facility that's driving these numbers. So, you know, an employee could go on a website at Safeway. They were looking for a treadmill test. They could go to facility A or facility B. Facility A was $360. We introduced a concept called reference pricing. We said, you know, we're willing to pay X amount for a treadmill test. That's it. Anything above that would be yours. And so their copay would be $135 with facility A. Facility B, a perfectly good treadmill. We focused on what I would call commodity services. If you've ever had a treadmill test, you know, the most important thing to you is it was supposed to be at 8. Were they ready for you at 8? That's about it. That's where the quality comes in. And then, you know, anybody can keep track of your heart and the heartbeats and the time and the recovery and everything. It's a commodity. The guy that you want to read it is the world-class surgeon, but the testing is a commodity. So by going to facility B, the employee saved $113 and the company saved $139. And we replicated that result. The first procedure we did was colonoscopies. We cut our colonoscopy expense in half the very first year we introduced this transparency. So let me just talk briefly about the future of healthcare as I see it. The marketplace is now responding with new business ventures to address, you know, the new set of opportunities. Employers, really across the board, are shifting to higher deductible plans to give their employees a bit more skin in the game. Some employers are abandoning healthcare benefit and writing a check to their employees. In fact, the biggest company to do that so far is actually Walgreens. And I'm gonna explain to you in a minute why that was a bad decision on their part. But they didn't want to subject themselves to future inflation. So they thought, well, what did we pay last year? We'll write a check. You guys can go out to the exchange. Good luck. It's a marketplace. And you know, fend for yourself. I don't think that's a great idea because the marketplace doesn't have all the tools for you to be a good consumer at this point. Transparency tools are on the rise and getting better. Technology is increasingly available to track personal health statistics. Some of those devices are better than others. And then, got to have a plug, companies like Burd Health, have been formed to help large self-insured employers. And every time I say that, somebody comes up to me afterwards and says, well, I have 100 employees, how about me? And we're not in that space, although we might be someday. So higher deductibles, that's a good idea because it causes health plan members to behave more like consumers. And the new consumers are putting pressure really on providers to provide cost and quality information. So if you do want to try to call for an MRI, they are better equipped today to tell you what that's going to cost you than they were, say, 5 or 8 years ago. And someday there will be online tools accessible over the internet. Abandoning healthcare, it really forces the employees to behave like consumers, but in a poorly developed marketplace. So they're kind of on their own. It also places the future burden of inflation entirely on the employees. And then the employer loses the ability to improve employee health. As an employer, I love that we could actually, we could help employees navigate. We could dramatically improve their health. I didn't say this on the earlier slide, but the biological age of our workforce, same cohorts, didn't hire younger people, dropped 4 years. So they became 4 years younger. When you do this, you deny yourself the opportunity to improve the employee health, lower their out-of-pocket spend, which makes you a hero in their eyes, and enhance their loyalty and their productivity in the workplace. And it denies the employer the opportunity to lower their cost, we think, 30 to 50%. So if they'd waited for Burd Health, they could have written a smaller check by 50%. But maybe we would have convinced them to actually stay in the game. So transparency tools are getting better, but are still not very helpful. They're largely based on historical data. That was true of the tool that we use. We reverse engineered 3 years worth of claims. If rates went up, we had a hybrid of costs in there. The tools are often difficult to navigate. If you only need an MRI, when you're 60, and it's your first one, and they gave you this information when you were 30, you're not likely to be able to navigate that website, at least in its current form. The information is often incomplete, and employers really need to make plan design changes. I made that point earlier. Otherwise, transparency isn't going to go anywhere. And of all the people that I think have bought into that transparency tool, I think Safeway was the only one that made substantive design changes to take advantage of transparency. The transparency, if I can go back to my analogy, if behavior became a form of currency to buy down your healthcare premium, then transparency gave us the outside marketplace so we could see cost and quality. And those two things together created the market. And if you've taken economics courses, there's the invisible hand of Adam Smith. I used to say that Adam Smith was managing our healthcare costs, not anyone in the HR department. Technology companies are creating products and services to improve wellness and lower costs. Some of these companies have some really fascinating technology. But technology alone won't solve it. I can't tell you how many entrepreneurs I've met with in the last 3 or 4 months, and they're pursuing these great ideas, but I guess you can still go public and not make any money, and that might be their hope, but they haven't really thought about the marketplace. They just are doing something cool. Oftentimes, these technology solutions need to find a market that bypasses the existing healthcare companies. It's a clumsy way of saying disruptive innovation, more often than not, comes from outside the sector, not inside the sector. Okay, so when I was a kid, I watched a Zenith TV and an RCA TV. Did those guys invent the flat screen TV? No. Okay. Did AT&T or Western Electric, did they create the first cell phone? No, Motorola did. Who created the iPhone? Not Motorola, Apple. Okay, I could go on and on with examples. Disruptive innovations typically come from the outside because outsiders think differently. And I think the reason I think differently than others in the space is because I had $1 billion healthcare bill growing at $100 million a year. And that kind of gets your juices flowing and you start to think differently. If a company can genuinely improve health and lower cost, they have a ready market. So where does Burd Health fit in? We're focused on large employers, and the magic there is they're self-insured, which under the ERISA laws of this land allow them to design their own healthcare plan. And you can't do that if you have 100 employees. We have a unique portfolio of products that we think deliver transformational value. We offer 3 things to our customers. We'll materially improve the health of the workforce. We'll lower the company's annual spend by 30 to 50%. The reason I put 30 in there is I'm looking at a couple of large medical centers right now with 40,000 employees. And they might insist that we use their CT scanners and their MRI devices. So I'm lowering that down to 30 for them. And we'll lower the out-of-pocket spend for the employees. So it's a triple win there. And our go-to-market technique is unique. We think it's disruptive. And we align ourselves with our customers in that if we don't save them money, they pay us nothing. So it's basically a shared savings business model. I think that's my last slide. But I wanted to, yeah, it has to be my last slide. So with that, I think we were going to try to entertain questions, right?
Questions?
In the back, Genentech, Roche. X, okay. That automatically makes you good. No, I think pharma does some good work.
So I'm a complete advocate of the personal accountability side of it and managing one's own health. And I think for employers who are managing employee health care costs with them, this is a great solution. But how do you take this model and how do we put it in the space outside of that where there's more, the lifestyles are maybe not as easy to change because of the social or economic situation of the people involved, but actually where from a country's perspective, we could probably get much more benefit.
Okay, so let me give you I'll start by leaping one step away from large self-insured employers and then I'll go to the medical spend. 49% of the US medical spend is Medicare and Medicaid, okay? So in a non-large company environment, no one's yet done this. We could do it, where we would become an insurance company. I've been reluctant to do that because there's all kinds of regulation and compliance, and I'd have a bunch of compliance officers and lawyers, so it's not where we start. But I could create a product in fact, we're going to do some products for the uninsured. I'm going to make our pricing accessible to the uninsured population. That'll help them. But I think everything I said here you could apply in a Medicaid and Medicare world. Why do you pay a penalty for smoking at Safeway and then you turn 65, you're on Medicare, and you go out and buy a carton of cigarettes? That doesn't make any sense. And so for Medicare and Medicaid, you'd have to use something akin to what the economist calls shadow pricing, because money is not something they have a lot of. So what you might do is that you could do all kinds of things. You could say, as long as you're compliant with your medications, you can make an appointment. If you're not compliant with your medications, you have to come down here, get here early, and just wait. We'll fit you in when we can. Okay? That's a shadow price. It's basically their time. You could have the same kind of encouragement for people that are fit and well. So the behavior model works with Medicare. It works with Medicaid. You just have to make some adjustments because you're not living in a normal premium world. But I think it all works. One of the things that I tried to do, and you'll appreciate this, I met with several people in the administration. I met with the president a few times on this subject, dealt mostly with the healthcare czar, who's not the guy you see on television defending the Affordable Care Act. That guy you see is Zeke Emanuel, who did work in the administration under the healthcare czar. And I met with Zeke, and I I offered to do this for all 400,000 employees inside the Beltway. And I said that if we have to put the Senate and the House on this, we have to put the President on this, everybody, all federal employees, and 1 year from now, your costs will be down, quality of care will be up, everybody will feel better, and we'll stop all this debate. He thought about it for 3 weeks. I came back to see him, and he said, well, here's what we've decided to do. We're gonna have an RFP, which is a request for proposal. We're gonna send that out to maybe 100 people. And that will include the 99 people that have never done what you've done, but say they can. And they'll bid on this thing, and then we'll pick a winner. And then we hope to get 1,000 of those 400,000 employees to volunteer. And after 5 years, we'll study them and see what happened. And I said, don't bother to send me an RFP, because I won't show up. I later, 3 weeks, maybe 2 weeks before I left Safeway, I met with the secretary, and I said, look, here's my offer to the federal government. And I said, I'm going to make you a new offer, because I really don't want the government as a customer, because it's just a lot of baggage and red tape. I'll do it for free. And I said, what do you think? And she said, I have 80,000 employees. I don't need anybody's permission. I think I want to do that. And, then I left. She got caught up in trying to make the exchange work, and now is not in that job. I'm not planning on renewing that offer anytime soon, but if asked, I would do it.
I guess I'm just confused but on the incentive side, I'm thinking about some of the inner city areas where it's not that people don't want to do it, it's that the lifestyle is such, it is extremely hard
Sure.
to actually make those lifestyle changes because of the circumstances. And
Yeah.
so you're in a double bind.
Yeah.
You're paying a higher premium.
Well, I think what you end up doing is you end up building a support structure that is different depending on those circumstances. Because I didn't put a slide up here that looks like a puzzle with 40 different pieces. There are 40 different elements of infrastructure that we put in place to help Adam Smith and the rest of the people that work for us. And so you just design it for the unique situation. It should work. Where else? Okay.
I had a quick question for you. You showed a graph of the number of cell phones, and then over time the cost of it going down. As the choices increased, the prices went down for the consumer. You also did the same thing about the computers. Well, you showed a graph of the number of MRIs in the United States, yet the cost of MRI in the United States is much higher than anywhere else in the world, even in European nations. How do you explain that disparity?
Well, the disparity, I think, is pretty simple. Cell phones and personal computers in the United States, you buy those products in an open market where you have price and quality information readily available. And today you can go online. Remember, I'm old enough, the internet didn't exist when I was born. In the case of MRIs, you really can't do that. You can't get cost and quality information. And so what you have is you have an abundance of MRIs. I mean, there's probably enough MRIs today to service the world, okay? Because MRIs in the United States operate about 9 hours a day, and that's it. Well, most of us, if I price that by time of day and said, hey, it's $600, but if you're willing to come in, after 9 p.m. till maybe midnight, I'll let you have it for $225. Well, it's a lot more convenient for me to do that to begin with, and I love the cheaper price. It's really because almost nothing in healthcare, an example I can think of is LASIK eye surgery, where it's in a different space and there is cost and quality information available, but on MRIs it doesn't exist. I can show you a $7,000 MRI in Oakland. In fact, the most expensive place to get an MRI is at a children's hospital. And here's the reason for it, if you just think about it. People like Oakland Children's Hospital, I think all children's hospitals, they hold themselves out to take any child and treat them, which I think is a very good thing. so when they get somebody that's fully insured, it's no longer a $3,500 MRI. It's $7,000. Okay. Now I believe you could push back on that and get a better deal, but that's why MRI costs are not coming down.
But
go ahead. Here's another question.
But the patient, when they're hurting, tend to not to be able to shop as well.
Sure.
And you know, you're absolutely right about the disparity of the cost from one side of the bridge to that other side of the bridge. But that has a lot to do with the insurance companies. The 26 other industrialized nations that achieve a better healthcare quality at a half to a third of the price the way you showed, they don't have insurance companies. And I'm surprised you wrote off a single payer national healthcare in the beginning of your talk.
I will tell you why I wrote it off. I don't believe the explanation for those lower costs is that they're single payer systems. And you know, I had 225 stores in Canada. When I had an executive call me and say, look, my doctor thinks I have a brain tumor. I need an MRI. I can't get one for 6 months here in Canada. You know, I'm really nervous about this. Can you arrange for an MRI in the United States? And I would say yes. And they flood across the border to get those MRIs. And so it's not the single payer. My objection to single payer is there's so much inefficiency in the system today. And I do not think insurance companies have been universally good participants in the game, okay? There's so much inefficiency. If we remove the inefficiency and let the market work, wonderful things will happen and costs will come down. And we can have free choice, we can have high quality, and we can have the same costs that you see in other countries. And the other countries suffer something on the service side. And you're correct, you alluded to some statistics. I could have shown some here. You know, the best technology exists in the United States. Technology used in most parts of the world were probably people were trained here in the United States. But the life expectancy of a newborn is no greater in the United States than it is in most other countries. So there's a lot of contradictory information. But I would still tell you that you can, if you know how to find it, the best healthcare in the world is still here in the United States. But you have to know how to find it. You know, something as simple when I was diagnosed with prostate cancer and I needed surgery, I was able to find a surgeon who was 250 times better than the average surgeon. I mean, this is not some guy batting, you know, 450 and somebody else batting, you know, 200. This was an individual that had complications, you know, 2 out of 1,000, and the average surgeon was doing 500 out of 1,000 with complications. And the reason for it is that when a new medical standard, call it a protocol, is established, and who knows, I could be talking to a cardiologist here, but according to the New England Journal of Medicine, it takes 20 or 30 years for that best standard of care to be working throughout the entire delivery system. Because, you know, doctors, and I would tell you pharmacists too, it's as much, there's art form and then there's sort of science. We can design a healthcare plan for our clients that it doesn't take 20 years, and we can bring them the best of technology and science we can bring them today by designing a healthcare plan that says, this is the protocol path we pay on, and you will get great care. So, you know, we could, you know, if you want to talk to me afterwards about single payer, we can do that. And if that's the only interest in the crowd, we'll spend more time on it. But in my view, it's not a good way to do it. You're sweeping inefficiencies under the rug, and you will add to service problems. Who else? Ken, you were going to make a comment?
Yeah, I just wanted to add, and I certainly agree with everything Steve said. One of the important points Steve made about things that we have to do is to use smart changes in plan design to help guide people. With respect to your question about MRIs, most health plans in the United States that a person who needs an MRI might face are such that the person is probably almost at or above his or her out-of-pocket limit. If not, the company is paying 80% of the freight, and the person really imagine if you had a plan instead that said, even if you're at your out-of-pocket limit, we're going to reference price that puppy, and we're only going to pay, as a company, $300. If you want an $8,000 MRI, then $7,300 is out of your pocket because we're going to raise your out-of-pocket limit. That's what we did with colonoscopies at Safeway. And when we did that, the year afterwards, we had no colonoscopies up in Northern California, close to that $7,200 range. And we also had no fewer colonoscopies than we would have expected based on the aging of the population. So I think we demonstrated to our own satisfaction that when you price things rationally, when you educate people and give them the tools so that they can make intelligent choices, they will behave towards retail medical products and services just the same way that they do towards groceries, automobiles, I won't say gasoline because people are irrational as heck about gasoline, and apparel. And the problem is that our systems and our structures, by and large, are woefully lacking on that dimension.
Yeah.
Steven, in your example of the MRI to a fully insured patient at Children's Hospital,
Right.
the hospital is going to charge them the $7,000, but isn't the insurance company going to have some kind of a contractual allowance with that hospital and actually pay them much less than the $7,000? And doesn't that play throughout the system?
The $7,000 is with the insurance company discount. I can give you countless examples all across the United States where the highest MRI cost in the country is in a children's hospital. To go back to a comment that was raised earlier, you know, if you are wheeled into emergency, this is not the time to shop for price, okay? But the vast majority of CT scans, PET scans, and MRIs, you walk in and have them done, all right? And so I've got a particular client situation where 99% of their CT scans were done in the hospital, and 65% of those were outpatient. So they came into to see their physician. You know, let's take UCSF. All physicians are on salary. You come in and see your physician. Hey, why don't we do a CT scan? I now know physicians at UCSF that when they understand the economic situation of one of their patients, because they serve the wealthiest of people in the Bay Area, and they serve the poorest of people in the Bay Area. I've known them to ask their assistant to spend 3 hours on the phone finding an MRI that costs 10% of what UCSF might charge. And that seems like, you know, it's contrary to the best interests of UCSF, but I would say in the long run, it's consistent with the best interests of UCSF.
Steve, we'll take one more question.
Okay.
Thank you. First of all, I want to thank you for probably the best presentation on this subject I've ever heard. Right to the point, and all the important facts and figures presented. Excellent. Thank you. I want to know how long you think it's going to take for an ordinary person to get access to cost information. Because without it, you know, if we're not already working for a self-employed company that has the tools and the power to get access to the information, we're sort of left out.
Yeah. You know, it's here's the way it'll happen. As people, employees, end up with a higher deductible plan and maybe a bit higher out-of-pocket expense, they'll start looking for and demanding this. There are some occasional websites out there that you can go on today, you know, low-cost MRI. So it's starting to happen. The other thing that you can do, absent that kind of transparency, people can build low-cost, high-performance networks and offer them up as an alternative to pure transparency. And so that will also take place. I think as people get smarter about healthcare, they will demand things they don't now know they need. And once they have more personal skin in the game, they start behaving differently. I mean, the opportunity for, you know, people to be healthier and to my Hawaii speech, you know, live longer and have more money, is available to the vast majority of people. And but you know, they need to be motivated to do that, and this is why we like working in the self-insured space, because I can go to a company with 100,000 employees, and with dependents, that's 200,000 lives, and I can affect all of this for 200,000 people. And we think we'll create some of those websites I just described for the uninsured, because I feel they're paying the most because they're subjected to the rack price. I remember meeting a guy on the East Coast, and he was telling me that his wife just had a baby, and he didn't have insurance, and he owned a little bike shop, and he got a $7,000 bill, and he talked him down to $3,500. I felt badly for the guy because I could have talked him down to 1/4 of that $7,000, because I knew what the rack price really was, and I knew it was just there when a very significant hospital chain in Northern California was confronted recently by a reporter for some of their outrageous pricing. The only thing they could say in their defense was, well, you know, that's just the starting point for negotiation. Well, most of us didn't even know you could negotiate. You know, if you don't have insurance, you have no choice but to negotiate. And so those with insurance didn't really know these things were negotiable up to this point. All right, I think we're done.
Thank you, Steve.
Thank you.